I've gone from quite a long career in hospice, 18 years probably, looking at the hospital through that lens. Then there's been a gap looking nationally, an overview, working at Hospice UK, and now back working in an acute cancer hospital. It's really fascinating looking at hospices through a different lens or through in the other direction. But I haven't got time to tell you about those perspectives. I've just got 10 minutes to really think about outcomes in hospital, particularly in a tertiary cancer hospital, and what we're learning and what's relevant to hospices too. So I'll start off with a patient, because I always do. So Steve is an inpatient at the moment. He knows that I'm presenting his case. It's not his real name. He's a Scottish young man who works for the Ministry of Defence. He's got a horrible spinal tumour, an upper spinal tumour, that has caused weakness of both arms. So weak that one arm doesn't move and one arm does a little. And he's had surgery, radiotherapy, and now in the middle of chemotherapy, and he's got overwhelming pain and huge anxieties. His goals, when I first met him a few weeks ago, were about being able to text. If you've got two hands that don't work, it's actually quite difficult. Being able to manage in the toilet on his own, 27, doesn't want anybody to help wipe his bottom, and wants to get married. And he did have a wedding planned for 3 weeks' time in Edinburgh. So let's remember Steve. So, oops, this hasn't come out very well. Let's see, oh, there we are. Does anybody know of this article that was in the BMJ in 1992? A very irritating, if I'd met him, Scottish GP, who famously said hospices are too good to be true, and it's funny, somebody earlier on has just talked about too good to be true, I think it was Steve, and too small to be useful. Now that was 1992, 25 years after St Christopher's was founded. 25 years on, we need to think, is he still right? It's a very funny article. It's a real dig at hospices, but underlying it all was a plea for the NHS to take on palliative care, and that care of the ill and dying shouldn't remain solely in the charitable sector. That is a whole other debate. But we need to think about how have we made any progress in disputing his provocation. So my definition of palliative care has always been about we work in the midst of uncertainty and suffering, and of course that's not measurable. I thought that for many years. And I will also argue with Antonia that lovely letters don't mean anything. Now, I've got thousands of them dating back 18 years. We kept them all. And we've done a thematic analysis of nearly 942 lovely letters and the things that patients and families mention about what makes a difference to them. And it is things like safety, listen to me, I could have Marmite in the middle of the night. So they have a value, but of course Dame Barbara Monroe said that we need more than a drawer full of thank you letters. And she's right, and I gradually learnt that. So the way I've always thought about the value and demonstrating value, we've got our lovely letters, which is the difference we make to how people feel. We're very good at activity data. That's a whole nother story. MDS data. Now, we don't have time to discuss the MDS and its decline, but you should all be sending our activity data to Hospice UK because we are still counting it. So I hope you're all aware of that. So we're very good at counting what we do. We're probably very good at looking at experience in, albeit a very qualitative way. But are we good enough at actually measuring the difference we make? Probably not, but getting better, as you've heard this morning. So, there's lots of evidence, and I know Fliss has got a side, there's lots of evidence about what really matters to people, and this will all seem very familiar. It's about being listened to, getting symptoms right, information, family support, and coordinated care. So I've been working at the Royal Marsden now for 2 years. It's a tertiary cancer hospital with referrals from all over the UK, specialises in sarcomas particularly, but all cancers are seen, but they're usually second opinion when other treatments have failed. So almost everybody has got metastatic disease, and the palliative care team sees 30 to 40% of inpatients at any one time. So our caseload, it's a small hospital, there's only 120 beds, and we've usually got about 40 patients on our palliative caseload. So, yes, sorry. We have a great interest in outcomes and have been using them in 3 different areas, mainly in research to date, increasingly now looking at the difference between cancer sites, how teams are working, and obviously individual patient, the difference we make, but also hugely important now in demonstrating unmet need and using the evidence to apply for new workforce and money to support research. So, research, now these, I'm stealing slides from Jane Wood and Joanne Droney. Most of you will know that there's increasing evidence that the earlier we intervene with patients, we can make a big difference. So early intervention is really a key interest for cancer hospitals and should be for all of us. We don't quite know yet how to do it. So, the London Palliative Care Group have developed collaboratively, this is before my time, 7 triggers to trigger early referral of cancer patients, all cancers, to palliative care. And they're sort of obvious. They're about metastatic disease and severe symptoms and poor performance status. So a key research trial, the Triggers project at the Marsden, is looking at lung cancer, non-small cell lung cancer. So if you are trigger positive, i.e. one of those triggers are met at your first clinic visit, then you are referred to a nurse who will support you to do your IPOS score. So if you're triggers positive, and actually we've discovered that 80% of patients are triggers positive at their first meeting in the clinic, if you're triggers positive, IPOS is done. And there's 3 different ways of responding to the IPOS score. If you're in the red zone, then there's an immediate discussion with the hospital palliative care team. If you're in the orange zone, then we immediately discuss or recommend urgent referral to the community team. And yellow and green, there's obviously a different response. So the Triggers project, I think I've just said that, 100 patients have been seen in the first 4 months, 73 are trigger positive, and a huge number, 81%, had a severe or overwhelming symptom on IPOS or result on IPOS. And that's significant because these are people turning up to an oncology clinic with really overwhelming problems. And guess what the problems were that were mainly overwhelming? Who's going to tell me? Fatigue. Fatigue, yeah, this is lung cancer. But the highest scores were family anxiety and information needs. These have just been presented in Madrid at the European Oncology Conference. So those of you who are used to looking at the way IPOS can be demonstrated, it just shows that the anxiety and the psychosocial measures are really high. So everything that is orange or yellow, orange or red mean those are the numbers of people who had those scores. I know it's difficult ways in a session to look at slides and get it, but really that red squiggly line reflects the people beyond that line are the highest number of people with those scores. So psychosocial support. And there is very little psychosocial support at the Royal Marsden. There should be more. And that was a big learning point for me going from a hospice to a hospital. I was used to looking over my shoulder and having social workers or people with psychological or family support skills, particularly if there were young children in the family, and there isn't enough at the Royal Marsden, yet they are seeing really people who are really distressed and are not yet referred into local services. So I think I've just said that, information needs and family anxiety. But this links really closely with my other big interest, which is about how we assess and support carers. And some of you here will be using the CESNAT tool, I hope. Who knows anything about CESNAT? Okay, so the Carer Support Needs Assessment tool developed by Professor Gunn Grand and Gail Ewing. This is going to be huge in the future. If we accept that carers are part of our health professional team or our health team, they do 90 or 95% of the care. We need to understand what their needs are and how to support and coach and empower carers. And IPOS is demonstrating this unmet need. And globally, CESNAT has been used in Australia and Canada and in the UK. And if you analyse all the returns from initial carer support needs assessment, it's the need for information and what happens next. And that's why this house here in Sheffield is going to serve a really useful purpose, and Judith's going to mention that. So IPOS is demonstrating unmet need, which helps us to plan services better. Patients. I'm really interested in how long patients on the ward are unstable for. So phase, if you just do phase, and for a year, the hospital has just been looking at phase every time a patient is seen, and that gives us very easy data to look at the unstable phase. And actually, as Fliss mentioned, the more senior members of the team concentrate on the patients with an unstable phase. This shows the number of patients who were stable and became, who were unstable when we met them and became stable at the time of discharge. So that's useful. And it's useful for our team, and we're also looking at different cancer sites to see if there's longer periods of instability, because there's a huge amount of bowel obstruction in the hospital, and it's really difficult to get those symptoms stable. And so what we actually do in the hospital, we measure phase every time we see a patient. We measure AKPS on the day of the MDT. So everybody's performance status is measured on a weekly basis. And now IPOS has been implemented, but probably just for a few months. But what's interesting is that the Royal Marsden was one of the pilot sites for, Fliss will know this, for the Palliative Funding Review a few years ago. So the whole, the palliative care team got very used to using IPOS, and then it dwindled when that pilot ended. And suddenly there's no experience. So we have had to revamp it, and we have champions now within the team. At the moment, it is only used by the palliative care team, but we really are going to train up lots of the other wards to use it. Because, as I said, most of the hospital is palliative, but you wouldn't know from the Royal Marsden branding, because their branding is they cure cancer. So that's a slight problem. And this is actually a slide from when there was a lot of IPOS data from 2 years ago at the end of the funding review. And what it showed is that the biggest difference that can be made is in the unstable phase. So if you look at that red line, which is the number of patients where there was a big reduction in IPOS score, particularly their pain score, but we've done this for all of the different IPOS measures. There's a smaller reduction in family anxiety, a big reduction in information needs, so everybody feels more informed. But obviously in a hospital or in a hospice, you would expect rapid improvement in pain and nausea and the things that we're very good and can make a difference to quickly. So I've only got another couple of minutes. Potential benefits to patients are huge. They're the same as using outcome measures in hospices, better holistic assessment, and when the CNSs are busy, every patient, every new referral on the ward is given an IPOS assessment unless they are confused or active, I hate that term, actively dying. Anyway, if they're dying or unconscious or muddled, they don't get given an IPOS to complete, but everybody else does. And we are really bullying the team, registrars and CNSs, to do this. And we've already got hundreds back in the first 6 months. The hospital team sees 1,500 patients a year. So the nurses are now, having gone from a resistant mode, are now seeing that looking at the concerns that patients express in the top 3 items, and then looking at the IPOS scores, it does give them a focus if they've got to make a quick assessment. So it's really useful. I don't think it was ever designed to do that, but it's useful in practice. And I've talked about unmet need. And we are beginning to set ourselves targets for next year. So we would like to have people in the unstable phase for a short period of time, whether that's 3 days or 2 days. That might be ambitious. And we want everybody to have certainly their physical symptoms at less than 2. So the opportunity to set targets, and we all love targets, but we will get the teams to set their own targets. And I think these are obvious and have already been mentioned, benefits to the hospital. So I'm particularly interested in whether we're focusing too much on the physical. And if somebody gives me a microphone to talk at, I can say what I'm interested in. I'm very interested, having gone back to work in hospital, that there's a huge focus, because I also work, the Marsden team covers the Brompton, and that's a whole nother ballgame. So that's all heart failure, or everything that can possibly go wrong with hearts or lungs, and have got diagnoses that none of us understand. But anyway, my sister is a renal physician, and we were recently doing a session together, and we came up with the idea of event-centred care. And that's because when you're go into a hospital, how many minutes? 1 minute. Finish. Shut up. Okay, I get the hint. Cues, communication skills. That we focus very much on the bits of the body that we can improve, but we don't really look at the whole trajectory. And that happens in the Royal Marsden too. So I'm interested in the change of mobility, because that comes up very high on IPOS. A lot of people being referred to the lung cancer clinic score quite highly on concerns about mobility. And this was a workshop I did when I was at the hospice, where we asked people what the concept of home meant. And everybody shouted out garden, familiarity, children, photographs. And then a physio in the room shouted out stairs. And everything changes when you can't do stairs. This is my favourite cartoon. But this is the problem. Can we keep people happy for a long time? And I think I've nearly finished. Yes, just to say, my particular interest is the unmet family anxiety and how we address that. That boils down to assessing carers, discovering who matters to people, upping our skills to manage family meetings and psychological skills. We should be good at that in hospices, are we? That's a whole new research project that's going to start. But we certainly also need those skills in hospital. So discovering who matters to you. I've already said this, so this is the gynae oncology IPOS. Again, patients were anxious, families were anxious, and information needs, and we are putting a case together for a social worker to work with the gynae oncology team. And so back to my patient Steve, my last interest, and I've mentioned this to Fliss at coffee, is how we link our outcome scores, our improved pain, our improved anxiety to the goals that actually mean something to the patient and their family. Because improving the pain for me is not enough unless Steve can actually use his phone and get married. I hope he will. So I would say to Colin Douglas, I don't even know if he's still alive, hasn't been shot by a hospice chief executive, he does reflect that hospices started off with innovation and trying to demonstrate a difference. We need to carry on with that work now. And my questions for the team at the Royal Marsden, I've got a few research questions that we're going to look at. What makes us decide that a patient goes from deterioration to dying? What happens in that team discussion with the oncologists, with the dietitians, with the palliative care team? Why do we decide? How do we decide that somebody's dying? How can we influence family anxiety? And how can we link outcomes to goals? And that's it. Thank you.